Good afternoon, everyone. Welcome to this webinar. And I think we were very excited by this webinar because it's World Schizophrenia Day. And it's hard to know whether we should celebrate World Schizophrenia Day, but I must say to you that I'm going to celebrate it because nothing else celebrates schizophrenia. No one else celebrates schizophrenia. And those of us working in the field feel that it's a condition that is poorly understood, has a very bad reputation, and undeservedly bad reputation, that not only do our clients suffer the stigma, those of us working in the field also suffer. I'm just going to request people to switch off their sound if possible. I'm surprised you were able to switch it on because I thought we had set it to a point where it would not be audible. Please switch off your audio if you're not speaking. So that we are recording this. Please be aware of that because we've got an excellent speaker in Dr. Kalyanasundaram, who I think, we sometimes refer to our patients as and our families as experts by experience. But Dr. KS's expertise, I think, is multidimensional. He is someone who has been a leading academic in the field, but also unusually, not only that, but also an amazing clinician. And I know we've introduced him as somebody with more than 4 decades, but I think it's closer to 5 decades of experience. When I say to my patients, when some of them says, I'm going to this doctor, I said, I've only been a doctor for 25 years. Dr. KS has been a doctor for 50, and his expertise, although he's an expert in many things, I think we are today asking him to speak on a subject that is closest to his heart, also something that he has extraordinary experience in. And that's why I'm so delighted. And it's a conversation. I think Dr. KS felt, look, it shouldn't be a didactic lecture because he's very good at that. We've been to his talks. They're riveting and they're amazing. But today we were going to talk about things that really matter to families. Family matters to clinicians. This problem that we're going to talk about today is something that gets in the way of treatment in almost every patient with this condition that I've ever met. And if it hasn't got in the way of the treatment, it will get in the way of treatment at some point. And so without further ado, I think with Dr. KS, he's truly one of those people where we say he doesn't require any introduction, and then you'll go on to give him a 5-page introduction. He's an extraordinary clinician. He's probably the most famous clinician in India working on this area. Number two, he's also somebody who has steered Richmond Fellowship Society Bangalore to what it is today, to its preeminent position. And he remains at the head of that organization. And also, he has a family experience of this condition that is unique. Very few of us psychiatrists can claim to say that we know what it feels like to have this illness in our family, in our midst, and to actually be on the other side of this. And Dr. KS has that, and to his credit, he has never hidden it. He's always used it to improve his communication with his patients and his expertise. And I'm hoping that all three of these will come today. A word about our audience. We're already getting quite a lot of people, and I'm not surprised. There are clients and patients. There are families who are experts by experience. There are advocates. There are also students, all our students, whether psychology, social work, psychiatry, and there are colleagues. So it's a really rich audience. I'm delighted. This is a conversation. So although I'm going to ask Dr. KS maybe to set us off from the beginning, I would be very happy if you would put in the chat box any questions that you have, and I will put them to him as and when you ask, and we can ask. And I suspect we will go over the 1 hour mark because we usually do. And I've set this thing for 90 minutes, but I suspect we will have great difficulty keeping to that time. So thank you to all of you for joining, and thank you particularly for Dr. Kalyanasundaram for agreeing to talk on this very important day on a subject that is close to his heart and mine and to many of yours. Dr. KS, over to you.
Thank you, Dr. Aditya, and my dear friends who are in this audience today. He's been more than generous in talking about who I am, what I'm capable of. I don't know whether I can fit into all of these expectations, but I try my best. One thing I tell people when they meet me, first consultation, second opinion, third opinion, I tell them, to me, I'm starting afresh with you. I'm an optimist. I don't give up. Dr. Aditya himself is a very fine clinician, trained in Bangalore and trained in Scotland and worked in Scotland for 25 years. He has come back to run his private psychiatric nursing home. In fact, it was the first private psychiatric nursing home started in Bangalore by his father. Many of the senior members were here, would have known of him. Dr. H. Subramaniam, a fine clinician and a professor of psychiatry, both at St. John's and St. Martha's Hospital. And he has passed on the legacy to his children. His sister is a psychiatrist. He is a psychiatrist. He has come back from Scotland to our good luck, and he runs his nursing home in Jayanagar at Ashoka Pillar Road. More importantly, he is my colleague and currently the CEO of Richmond Fellowship, and he has taken over from me when I offered to step down about 5 years ago. Technically speaking, I report to him. And I'm continuing in the field of Richmond Fellowship with Richmond Fellowship for over 35 years I've been here, but I'm asked to continue as an advisor. So I'm around with this place. As I tell people, Richmond Fellowship is my passion. I eat, sleep, dream Richmond Fellowship. But psychiatric illness and psychiatric illness recovery and is something which is ingrained into me. Dr. Aditya mentioned somewhere about a family member, maybe somewhere down the line, it might come up if it is appropriate, and I will share that with you. That we discussed about this about 4 weeks ago, that we must have a conversation on schizophrenia and how do we manage people who are unwilling to take treatment? How do we handle them? If they're unwilling to take treatment, how do we make them take treatment? What happens to the family members? So these are the questions that we constantly face on a daily basis. We said we should share this. We should share this information. So here is Dr. Aditya. It's going to be a question answer session. If I find the question difficult, I will bounce it back to him.
Thank you, sir. Can I start? Because it's World Schizophrenia Day, and although we often say to people, everyone knows what schizophrenia is, I must say time and again when I meet families with schizophrenia and I ask, what is the condition for which you come? Many people use the word depression. It feels to me that depression in India is a word that is an acceptable face of all mental illness. Perhaps it's a euphemism, but there is also some lack of information. This idea that schizophrenia is like everything else. But those of us working in the field know that it is unlike everything else. It is something that we have a lot of respect for. I often say to my patients, I have a lot of respect for it because I don't have much control over your illness. So would you start us off, please, by telling us a little about what is schizophrenia and why do most people with it not believe that they have an illness? Almost uniquely of all the illnesses in the world, of all healthcare, why is it that people, what is schizophrenia and what is it about schizophrenia that means that people who have it almost uniquely never say that they are completely well and they suffer from nothing?
All right. A lot of questions in one breath. What is schizophrenia? Schizophrenia can be seen or can be understood as one of the most difficult, debilitating illness of all varieties. You take any psychiatric illness, among psychiatric illness, it is the most difficult. It's a condition which starts pretty early in life, late teens or early 20s, starts very insidiously. You don't even know it's happening around you. It starts in a very low key. We ask people, how long have you had this problem? They can't put a finger on it because it starts very slowly. It gets into your system. Before you realize that there is something wrong, more often than not, 6 to 8 months, 1 year has passed. We call them prodrome symptoms. Prodrome symptoms are those where there are subtle changes in the individual. Person is not attending to classes. He's showing lack of interest in routine things. Doesn't want to get up and go to office. And something very unusual and odd about it. You can't put a finger on it. And you think something very different, but it will pass off. It doesn't. Slowly, gradually, the person begins to withdraw. And while he's beginning to withdraw, something else that happens. His scholastic abilities as a student in a college or high school starts dropping. Doesn't attend classes. Doesn't get sufficient mark. would have talked about 85-90% in SSLC, but drops in first year PUC 75%, second year PUC attendance is barely 25%, and it doesn't have an exams. Why? People think he's not interested in education, but what is happening is something that is happening in the brain. He or she does not realize this. The families do not understand this. People around them do not know what's going on. Slowly, the brain begins to have some damage. So we call this cognitive deficits. Cognitive deficits are the first one that appear in schizophrenia because it is slow and insidious, and you do not understand what's happening around you. But people watch it, see this, they do not know what it is. They ascribe several reasons and rationale for it. Then he begins to withdraw, begins to isolate himself. When I say he, I mean she too. Isolate himself, shuts himself in the room, doesn't want to come out to eat with everybody else. If visitors come, he says, I don't want to come out. Tell them I'm not here. His friend circle slowly dwindles. He spends time in his phone, with his phone. He wakes up in the night, pacing up and down. This goes on for a few months. So we call this negative symptoms. Suddenly one day, he comes out and asks his parents, who was that who was tapping my phone? Who is hacking my computer? How is that people talk about me in the television? Who is leaking things about me and my family? Patients, families, things, what is wrong with this person? They say nothing is happening. He gets angry, he is abusive, he is irascible, he starts shouting and screaming. That is the time they wake up. He begins to believe people are listening to him. People know his thoughts. They remove his thoughts. They insert some thoughts into them. He's suspicious. Neighbors are watching him. When he goes out, people have a camera all around the area. So he doesn't go out. And he gets angry and upset and he becomes delusional. That's the time families wake up and say, hey, something is wrong. So as Dr. Aditya asked, it is not easy to identify this as a problem because it is slow, continuously happening, and so-called positive symptoms. The person is aggressive, sleepless, starts shouting, screaming, breaking things at home. They wake up and then come running to the hospital, running to the doctor with or without the patient. That is why it is difficult to identify it at an early stage. We often ask, why have we come late? And that is why they come late, not because they want to come late for the first few months or 1 year. They don't even know a problem is happening.
So the question I had for you is, why do patients struggle to recognize that they themselves are ill? The families, I understand, because they may not have any context to this kind of a problem, never heard of it before, never seen it before. But when a patient is suffering, and they're suffering a lot, you can see they're suffering, but they are almost uniquely defended against it. And they'll say, no, I am completely fine. It's all these people around me. When they come, they're the ones troubling me. I think you had referred me a patient yesterday. One of your patients is a inpatient. And they said to me today, even today, just about half an hour ago, said, no, it's my husband, it's my son, it's them. If they stop troubling me, I'll be fine. I am not giving anyone trouble. I'm perfectly okay. What is it about schizophrenia that seems to blind our patients to their own predicament?
Very interesting question. Now, when they undergo this problem, which I would like to reiterate here, schizophrenia is a brain disease. And even before the symptoms begin to appear very prominently, there's already a brain damage that has begun to happen. The more you delay the treatment, the brain damage continuously is happening in different parts of the brain. What is unique about the fact that they don't recognize it's a problem? Because the experiences they have, I talked about hearing voices, suspicious, people are watching, hacking, there are cameras. When I'm having a bath, the lady comes and tells us, somebody's recording it, I can't even go and have a bath. They're asking me, why have you not had a bath for 1 week? I can't tell them, but I'm telling you, doctor, they're recording it. It's coming out. It's in the social media. I hope you have not seen it. Now, to them, these are so real. This is the reality with which they live. They operate in a completely different reality compared to so-called normal people. And I tell them, I give the example I give them is, if you want to tune into an FM radio, you can't say, I have an AM radio, I can tune into FM radio. You can't. You're operating in a completely different frequency. The frequency in which they operate are so real to them, everything else is unreal. They function at their unreal space. You see them smiling, giggling to themselves, out of the blue, for no reason at all. The family members, I said, no, I didn't smile. I asked them, Dr. Aditya asked them in the clinic, what made you smile? No, nothing. What did you think? I was thinking of a joke. Standard answer. A person is going through this pre-morbid, prodromal symptom, negative symptom. You find a person smiling, laughing, giggling, talking to oneself. Beware. We are almost always dealing with schizophrenia. Anytime you have a suspicion, you need to take them to a doctor, to psychiatrist. When I say doctor, I mean a psychiatrist, to understand whether we are dealing with a condition that we need to address it very seriously. Because they are completely in a different space and they are not in the reality that we think is the reality. They are not able to understand this is an illness at all. That's very unique. That's very confounding, confusing. And remember, they are going through their own mental distress inside, not able to find an answer to several experiences they have in their brain. They are struggling themselves. You ask them, they don't have an answer. When you don't have an answer, you get to be very irascible.
I think we have used the word insight, and I think insight is a word that we in mental health use a lot, but I know it's not used a lot in common English. So would you be able to tell us a little bit about what is insight? And there's a second question coming up, but I will try not to make it complex. So what is insight for all of us? How would you best describe the concept of insight and why is it so important?
Let me give an example. Let's say somebody is walking down the staircase, slips and falls down, breaks the ankle bone. You're hopping, it's painful, there's a swelling, and you try to put an ice pack, and you want to go and see a doctor because you want a painless remedy, you want maybe surgery, whatever. You know you are ill, you know you have fallen down, you suspect there is a broken bone, you want to see a specialist, you want to go for an X-ray, you want to get a treatment done. You are aware of what is happening with you and your illness and your physical state. You have insight into the fact that you have fallen. You have insight into the fact you have injured yourself. You have an insight into the fact you need help. You know where to go. You know what treatment to get. And you will follow every instruction the doctor gives, the orthopedician gives. Look at psychiatry. Look at schizophrenia. When I'm experiencing all of those things that we are talking about, they do not believe they are ill. They don't know they are ill. Insight is an understanding and awareness of one's mental and emotional state. Please watch the words very carefully. It's an understanding of a fact that I'm mentally ill. Awareness of the fact I have an illness and I need help. And to understand that I have a mental and emotional state, I need help. I need to go to a specialist. I need to take treatment. I need to follow treatment without a break. This is asking too much for a person whose brain is completely disturbed and is not in their normal state of mind. Therefore, lacking of insight in schizophrenia has profound consequences. I'm sure Aditya is going to come to that a little later. It has profound consequences. If you lack an insight into your disease, you are not going to go and take treatment. You will not accept treatment. Why will I take treatment for a condition that I do not have? If I don't think I have a cardiac problem, will I see a cardiologist? I don't have jaundice. Why will I see a doctor? I don't have a diabetes. I've checked it. Why will I see a diabetologist? I don't have any illness. You call this as a mental illness. I don't believe this. I don't believe you. Just because you say it, that doesn't make me ill. I'm fine. So why will I take treatment? This has profound and consequences that goes beyond months and years in person's lifestyle, life itself.
Thank you, sir. And a question from, I meet a lot of junior psychologists and they use the word denial. Now I know it feels to me, they ask, is this denial? Is the patient in denial? And I must say to you, I have some trouble with that word because denial technically would be defined as an unwillingness to see the truth as opposed to an inability to see it, an unwillingness, whether conscious or unconscious. And I'm wondering whether my patients with schizophrenia are just choosing not to see the truth or are unable. Is denial the same thing as a lack of insight? What is your view on this subject, sir?
No, it's not.
Oh. I'm sorry, there's a voice from stage left. Please pardon me.
Okay. I think whoever is Galaxy, I think your answer is right. But let me elaborate because the question is from Aditya to me. I would like to give an example of an IPL that has gone by. I think I'm batting fairly well. I'm striking the ball well. I'm fairly comfortable. And here comes Aditya with a googly. The question is whether I'm going to defend it. I'm going to hit it for a 6 going on a back foot. Why is denial different? Denial is different from insight. Denial is not only with an individual, denial extends up to the families. Lack of insight is for the individual who doesn't believe he is ill. Denial is something where even the families do not believe the person is ill in the initial stage of the disease. They don't think this is the disease. Denial can extend from individual to the families. It's something that is not true. I don't believe this is true. That is denial. It's refusal to believe or accept something that is the truth. Denial is something that you refuse to believe and accept, but there is a truth there, but you are unwilling to accept that. Denial extends beyond the individual. Families sometimes come and say, I don't think my daughter can be ill, doctor, although another doctor said some name which we do not want to believe because she was a very bright student, you know. She was a straight rank holder. And my family members are all very, very bright families, intelligent families. One brother of mine is an IAS officer, another one is a CEO, another one is a scientist. This cannot come in my family. It's not possible. It might be something else. And Dr. Aditya very rightly began his introduction. Most people are willing to say two things. This is depression. Please tell us it is depression. They insist that it is depression. And secondly, we will go for counseling. Not to see a psychiatrist, but we'll go for counseling, for therapy, because this will rectify this. No, it's not true. So sometimes a patient is in denial and also has lacking insight. He doesn't believe he's ill, but he has no insight into the fact that this is like it's a mental illness, it's a psychiatric illness. You may not know the name. What we call symptoms, he dismisses it and says, most importantly, I don't need help. I don't need to take help. I don't need medication. Please leave me alone. I'm going away. You can't force him to take treatment if he or she is unwilling.
Thank you, sir. My psychology students tell me when they see my patients with schizophrenia with me, why are you not referring this patient for insight therapy? And I sometimes explain it, sometimes I snort, sometimes I will say, because the term insight therapy is a really good one, and insight therapy works in many conditions, but it seems not to work well in schizophrenia. What's your understanding? How often have you referred someone for insight therapy? Again, I sometimes say to my psychology students, therapy is not just what happens in a psychologist's chamber, but actually many of us are engaged in different forms of it. But maybe that's just me. But what do you think, sir? What is the term insight therapy? Is this something that, what has your experience been about this
To
and
answer
schizophrenia?
the question, have they referred anybody for insight therapy all these 50+ years? Answer is no. I have not referred. Why is insight so difficult to achieve? Insight is a very complicated status. It is not something which a person has yes or no. What is the insight? What's the confluence of everything that makes it an insight? Remember, perhaps the last thing that a patient will achieve, if at all, is the insight. In an illness, you can control positive symptoms. You can help people with negative symptoms. You can produce help with cognitive remediation. But with all of it, if you think you have achieved, and the patient will say, I have an insight, which you examine in great detail, and you both agree patient has an insight, it is not necessarily so. Improvement in symptom is not equivalent to gaining insight. The lack of insight is a combination of several factors and facets that happen in the brain. Cognitive symptoms, negative symptoms, all of them contribute to the lacking of insight. And how many patients recover their cognitive dysfunctions? How many of them get out of their negative symptoms? You go back and ask yourselves. Most patients, positive symptoms respond well, and the negative symptoms are tough to handle. There are no available medication today that will help negative symptoms. There are no clear-cut medication in spite of several advances that will give you back your cognitive dysfunctions. There are specialized techniques available. Rehabilitation is one area where negative symptoms are addressed very efficiently. Cognitive dysfunctions are done with cognitive remediation therapies. When a person with schizophrenia, years of illness, 25, 30, 40. In fact, last week, I saw a patient of mine who saw me first in 1976, 48 years ago. He's still with me, coming to see me. He has insight. He was unwell when he was a student, got better, relapsed, got better, got married, child is married. He knows he needs treatment. He comes and tells me once a year, I want to continue to see you, only to make sure, tell you and tell myself that I need help. I will never stop. So insight is a complicated thing. Most people have negative symptoms and cognitive symptoms persisting all around them. And these two contribute to lack of gaining insight, inability to gain insight. In fact, Aditya will bear with me, and my colleagues who are listening in Richmond Fellowship, we have patients who are with us for 30+ years, and they've been ill for 40, 45, some of them 50 years. They take medication because we give them. Have they regained insight? I'm afraid not. Insight, recovering or regaining insight may be a target, easier said than done. We would rather concentrate on what we can do rather than battling and banging your head in something where it is so tough to get back.
Thank you, sir. So with all this said, how do you begin to help someone who does not believe they need help?
We are coming into troubled waters. Sometimes patients' families come. They come and talk about, you have taken an appointment because my son who's 27, sitting at home, is unwilling to come and take help. And we want to come and talk to you. How long has this been going on? It's been going on for 4 to 5 years. Why have you taken help before? We tried to, but he was refusing to come. Why is it becoming important for you to come now? Because things are getting back to worse. What is it getting back to worse? He's not getting out of the house, and he's not eating food cooked at home. You think it is poisoned. He gets food from outside. So he's knocking at our gate 3 times a day. And he does not want to open the door of his room. He opens it by the fraction. We are supposed to push the plate inside, the Swiggy item inside. We cannot go to his room and clean his place. And when you open, we know it is stinky. The maid is not allowed to go inside and clean the place. We don't know how filthy it is. It is becoming unbearable. Therefore, we have come to ask you how to help him. This is one of the most difficult things a psychiatrist faces. And it is not uncommon. How do we help such people? So if they ask, is there any way you can get him to the hospital? Which means what? Is there any way one can force him to go to the hospital? He will not come. He will not go to a doctor even for cough, cold, fever. He will order something online and get it and take it for himself. Nobody is allowed to go to his house. Nobody visits him. We cannot go there. And suddenly these days he's becoming angry and screams and loud. And we can hear him talking loudly inside the room, arguing with somebody. We know there is nobody, but we don't know what. So how do we help such people? They have seen somewhere, read somewhere. Is there any way we can give him some medicines? How do we give if he doesn't take it? Doctor, we have heard some places, some doctors, we have read somewhere. Is there any way you can give medicines without his knowledge? This is an extremely tricky situation with the doctors. How do we give treatment to someone who has not seen you? We often tell them somehow try to get him for one visit. We will try to assess, try to give him tablet, try to give him an injection, try to, for ourselves, assess and help this individual just to confirm that our suspicion about the disease is right. Without seeing, without physically seeing him or evaluating him, how can we start a person on treatment? It's an extremely tricky situation. And sometimes in this context in India, several people, several doctors use some drops of medication which can be given to the patient without his knowledge, which is normally given in the form of tablets. If you won't take tablets, you will not come to take an injection. Somewhere we have to give something to prevent him deteriorating further when the family members suffering can come to some kind of a halt at some level. Is it ethical? Is it correct? Is it legal? There are several questions and several layers of questions. The way I look at it is, some people also tell me, some of them even tell me that, if he is not willing to take medication, we are willing to give it because we want to help them. The question that arises is patient's individual decision to take help. It is individual decision not to take medication. Is it enough not to treat him? Do family members have the right to help them or help themselves? Is it something that will need to be looked into? I want to give you an example of a patient I saw recently, a few months ago. He's an elderly gentleman in his 60s, retired from a private company, did extremely well, sitting at home, married for about 30-35 years, well settled, a very charming couple. 3-4 years ago, as he was retiring, he used to attend various get-togethers. His wife would go. He started believing his wife was probably having friendship with some of his colleagues. Some of his colleagues are in touch with her, messaging her, talking to her, which is all not true. And he began to suspect her fidelity. And it became so bad that he started abusing her, irritating her, questioning her to admit that she has to say she does have a relationship with some members of the family. some members of his. She of course refused to say that. And it got so bad, one day he dragged her into the courtyard of the apartment complex where they were living and asked in front of all of the other members, because he dragged her into the courtyard and screamed at the top of his voice, "Look at this woman, she's doing all of this." And all the members on the community were flabbergasted. And she was so upset, she decided that it's enough, she cannot live this life, and she wanted to take her life. Just prior to this event, the daughter, only daughter of them, got married. So they somehow persuaded this couple to, they came and asked me, I said, let him come once, let me see. He came and raved and ranted about this woman and said, I'm fine. They're trying to find fault with me. I have evidence. I have evidence. Show me what the evidence. He cannot produce evidence. So lo and behold, this went on for about 2-3 years. The daughter and son-in-law came and cried and said, can you do something? Otherwise, my mother is threatening to end her life. What do we do? Do we say he doesn't want to take treatment, leave him alone? Or do we say, if you leave him alone, what happens to the wife, who probably will end her life? And what happened to the reputation of the family, which is in tatters because of his behavior at the community where they live? The daughter and son-in-law come crying and say, can you do something? Please help. We are completely helpless. I have a view that if a person is unwilling to take treatment, that the family deserves help. I suggested they can give some drops, and the drops can help. And the wife had to keep the drops in some place, started giving the drops in some liquid which I had recommended. This went on for about a month or two. And every time the wife went out, he will ask her to either leave the telephone here at home, or he will have to give her a live location so that he can track where she is. Once they came to see me, but they bluffed and said they went to a jewelry shop. He wanted to know what jewelry you bought, show the receipt, send the receipt by WhatsApp. So this is how it went on and on and on. Long story short, with the drops of medication, in 3 months' time, he began to get better. And at the end of 3.5 months, he came to see me because he had developed some side effects. And now, on explaining to him, he understood the need for medication, started on medication to control the side effects, and is now relatively completely normal, slowly gaining the insight into the fact that he probably had some abnormality at that time, but is better on treatment. The example I'm trying to tell you is, if we do not intervene, the whole family would have lost their complete livelihood there. The wife, God knows what she would have done. And the children, the daughter and son-in-law. Sometimes we need to have some kind of a empathy toward the family members also to initiate treatment, and down the line, many of them come and take help. So in a difficult situation, one needs to stick their neck out and start helping.
We are in an unusual position, sir, that we've got to 100 participants, so a lot of people are waiting outside, can't get in. So if there are any of our students who are, if you can share, that will be great, and you can let more people in. Lots of questions have already come in, and I was going to throw the floor open. I think the question I wanted to ask you, because they are related to what you've just said, is Dr. Nirmala Srinivasan of fame has asked two very important related questions. One is, the first one is, what is your opinion on informed consent? And the second, which I think is related to what you just said, is it time that Indian Psychiatric Society, IPS, should apply for legalizing proxy treatment?
Let me come to the second answer first. Several colleagues the answer is yes. Are we lagging behind in trying to make this happen? I think we have lagged. We have lagged behind. We are not confident enough to say this is necessary, completely necessary. And I know several of my colleagues who profess this kind of treatment should not be given, but in their practice, I've seen them use it, which means when the push comes to shove, they think it is important to use it in a particular situation. Is it to be done? Yes. And should this issue related to mental health act or MHCA, whatever, I think it is important to address this and seriously make this relevant happen. Maybe there are safeguards. You can have two psychiatrists say, yes, this can be done because you don't want one individual to use his influence. Informed consent. Informed consent, I'm assuming it is from the patient who requires to be said, I'm willing to give consent to take help. Unfortunately, in psychiatry, it's a very dynamic illness. Schizophrenia is a very dynamic illness. Sometimes you're well, sometimes you're not well. You may have an informed consent when you're in a lucid phase of complete wellness. You're in a remission, you're on treatment, but not all people who are on remission and treatment continue to take the treatment. They relapse because they discontinue treatment. The informed consent given at the time of your wellness, will it become valid when the person is unwell, is something that needs to be looked at. Bipolar disease. You are in a depressed phase, you have a manic phase, your behavior, the way you handle yourself or the rest of the people around you in two different phases are completely different from one from another. So informed consent as a single linear event is not something it can stand its time all through. That is my point.
Thank you, sir. On a related question, I think just following on Dr. Nirmala's question, is a question that has bothered me for a long time, which is Dr. Nirmala has done a lot of work as a view on the right to treatment, the right to mental health. But what about a patient's right to illness? Is there such a thing? Can a patient do the wrong thing, live their lives? Everyone has not been treated. He lives his life, he looks confused and he looks perplexed, but clearly has made his own choice. Should we be leaving patients alone to their own fate and their own actions? If not, why not? Because this is a question that bothers, I think, all of us, but also many of the younger students that come through our service who are often troubled by the ethics of compulsory treatment or proxy treatment. They ask this question, should we be treating them at all? What is your view on that? Why should we treat? When should we not treat?
The fundamental training in being a doctor is to treat people who are ill. Will you treat somebody who has had a stroke and a coma? Is he going to give you consent? You treat. You say his brain is damaged. You say his brain is not functioning. He's in a coma. He's had a stroke. We want to get him out of that comatose state. That is part of a brain dysfunction. In a schizophrenia, where we know today it's a brain disease. We know today every time you discontinue treatment, the functionality of yours comes down a huge notch. Even if you restart the treatment, if you had responded in the first time in 4 weeks, you may take 8 to 10 weeks to respond. When you respond, you don't go back to the previous level of functioning. From 80%, you come to 60%. Third episode, you come up to 50% improvement. It takes 3 times the chance of recovering up to that point. So it's a continuous process of a further deterioration, relapse after relapse after relapse. Just because the person is unable to say, I want help, the fact that he's saying, I don't need help is part of his disease. Do we treat? How do we treat? Is it a human being who requires to be treated and we are willingly waiting and watching, folding our hands across our chest? I'm not one of those doctors. Somewhere, sometime, we need to take help. We see somebody, road accident. We leave them alone because he's not asking for help. Some good Samaritan. Why are we all not good Samaritans to treat them? I think we should. How? Where? How long? Should they take take the responsibility? These are questions that needs to be answered. If there is a sick individual, the individual needs treatment. He does not know he is sick. Therefore, I want to be left alone in the state of sickness. I'm not one of those who is going to sit and accept, yes, he is made the right choice. No, he's not made the right choice because he does not know even to make a good choice. He needs to be treated.
Quick question, sir, I think there's several questions. I'm just going to read you one, which is an interesting one, which is Sumit Guha. What is your view on Eugene Fuller's statement that 25 years of the Human Genome Project has been unable to discover the genes that contribute to schizophrenia, and hence the direction of research on schizophrenia in the US should move away from trying to prove that it is a genetically inherited illness?
Let me rephrase this last sentence. Schizophrenia is not seen as a genetically inherited illness, genetic vulnerability. If there is a family member, a parent has got schizophrenia, the progeny has a genetic vulnerability to develop the disease, provided there are certain factors that come into play. There is a concept called pruning. As you are going to be an adolescent stage, there is excess neurons that may get developed and they all get pruned. Like if you go to a barber, he prunes your hair to the shape that you want. When the pruning happens, sometimes there is something called excess pruning that happens in the brain. When the excess pruning that happens in the brain for reason we do not know, so there is less of a brain substance available, relatively speaking. That is one issue. And in adolescent age, there are several pressures we watch today. Academic pressure, relationship issues, drugs issue, social media complicating your lifestyle issues. All of those things are acting together. And if there is a genetic vulnerability, the chances that you trip into a disease where suddenly there is excess of a particular chemical called dopamine is flooding your brain, then you start developing symptoms, positive symptoms. Before that, by the description I gave, you have already had cognitive and negative symptoms. So, Fuller-Torrey's view 25 years ago, whether they should stop research in brain and schizophrenia and genetics, I'm afraid they will not stop. Maybe not in our lifetime. Maybe next 20 years ago, somebody has a similar topic. They will have a lot more insight into this topic than we have today. Then there will be able to show a gene for schizophrenia. It is elusive. A lot of things have taken generations to find an answer. But that does not mean we give up. But I'm not a geneticist, but I respect geneticists who are very keen on looking into this because their insight is a lot more in this area.
Thank you, sir. And insight seems very closely linked in some way to adherence. So a patient who does not believe they are ill seems unlikely to take the treatment that they are recommended or take it for any length of time. So this question of adherence, could you tell us a bit about why doctors are so preoccupied by this concept of adherence? Is it just as a thing of control because doctors like their patients to do what they say? Is it just that, or is there more importance? Why are we so preoccupied with adherence? Because I know it's something that it's something that preoccupies all of us. And I've just been seeing one of my patients in Kerala who has been very keen to come off his medicine. He's a young man with very severe schizophrenia, but has done very well, but has never believed he has an illness and now wants to come off his medicine. His parents and I have been trying very hard to convince him to take his medicines. At some point, we may fail and he may stop his medicines. Why do we care so much? Because I was hoping to hear from your expertise of 50 years to say, could you tell us all why you care that your patients take the medicine?
Aditya, you touched upon an extremely important component of the management of schizophrenia and a huge proponent of adherence. of treatment in schizophrenia. We're talking about schizophrenia today. And it's very important that if you do not adhere to the medication that has been prescribed, the chances are that you will definitely relapse. What does relapse mean? Relapse means going back to the same state of your symptoms and illness like you had at the beginning. You're on treatment, you stop medication, and you relapse. So you go back to the same hallucinations, delusions, suspicions, withdrawal. For every patient, when they relapse, they go back to the same set of symptoms they had at the beginning. Every patient who is starting treatment on schizophrenia, 80 to 90% of them will stop treatment at least once in their lifetime. That's what studies across the globe tells us in different parts of the world. In all my 50 plus years, I have seen only 1 or 2 people who did not stop treatment even once. One was my sister, and she didn't recover. She had schizophrenia. She didn't recover. Despite giving medication every single day, ECTs, and she died in 94 when she was 37, when we did not have this advancement in medication. Long-acting injectables, clozapine had not come to India. She also refused to take medication. I had to give her drops so that she could be continued on medication, but she continued. Other than that, maybe one patient here, there, most patients will stop medication at least once in their life. If you stop medication, when do you begin to develop symptoms again? It can be within the first 10 days, first 4 weeks, first 3 months, 6 months later, 1 year later. If the diagnosis of schizophrenia is correct, you will always have a relapse. Make no mistakes. If you do not have a relapse ever in your life, then original diagnosis is wrong. There are conditions called acute psychotic episodes due to several factors. Maybe an infection that can cause a psychotic symptom. A viral infection can cause a psychotic symptom. A drug you are taking, marijuana and other drugs, amphetamines to study, people take amphetamine to study for the exams. They get a psychotic illness and they get treated. They don't take treatment. They may not develop the illness again the next time. But the fact that you have had disease once, you are always vulnerable. You may get away by not getting. But if the diagnosis of the schizophrenia is correct, by definition, you have had the symptoms for at least 6 months, continuously, most of the time, most of the day. And that is schizophrenia with all the symptoms I described. 6 months. Somebody asked, do patients develop all symptoms? No. No patient will have all symptoms. There are cognitive symptoms, negative symptoms, and positive symptoms. I was just discussing with Dr. Aditya the other day. It's like taking a basket of dry fruits. You put a hand and dig a handful of dry fruits. It can contain 3 or 4 varieties, not all the 6 or 7 varieties in the basket. Some negative symptom, some positive symptom, and definitely cognitive symptoms. So you can have a relapse if you discontinue treatment. Anytime next year, later, 1 year, 6 months later, you will definitely get a relapse. So that is why adherence to treatment is very important. Dr. I'm glad you asked to use the word adherence than compliance. Compliance is something where you oblige somebody to take the treatment. Doctor asking you to take it, I comply with your request. Adherence is something I want to do it because it is good for me. There is a flip side to it. You start treating them, symptoms seem to disappear, they're back to college, they're back to attending classes, they're doing their exams well. Why should I take treatment? I'm all right now. The patient will say this, the family members will say this, a lot of other friends and relatives from across the globe will tell you, why are you taking this medication? One thing that is freely available in this country is free advice. When medical matters, everybody is a specialist. When it comes to mental health, everybody is a super specialist. And of course, there is Dr. Google. So, adherence is an extremely important component to prevent relapses of this disease. With every relapse, there is a further brain damage. There are sufficient studies which demonstrate with relapses, the spine, the neuronal structure, there are what is called spines, like you say, thorns in your garden, in a rose plant. The spines drop off. Therefore, connectivity drops off. The strength of the neuron becomes less and pliable. So they're not able to have a strong connections. If they do not have a strong connections, the resilience in the brain is lost. If there's a resilience that is lost, then there's a further damage. There is physical evidence of brain damage and demonstrated in all research studies. And there are pictures we have in our own slide sets, we can demonstrate that. Therefore, adherence is an extremely important component in maintaining wellness, health of an individual. And it needs the patient and the families working together along with their doctors, psychologists, rehab workers, all of them together. It's a combined effort for everybody. And I ask people, look, why should I stop medication? Why should I take medication? Why should I not stop medication? So I go and ask him, what were you like before you started treatment? Then we go back and revisit that state. Will you be willing to go back to that state? How do you know that I will go back? I tell them I've been working in this area for long enough to know this is it. And the science literature tells us this will happen. There are several like you who have were unwilling to take medication. They have relapsed. Unfortunately, multiple relapses will leave you dysfunctional for your life.
Thank you, sir. I'm just let you take a little break because I've been getting you quick and fast. I just wanted to say there are, again, we're still around 100 of, we're in the maximum number of participants, but also lots of questions. I was going to try and club a few so that you're not overwhelmed by the questions, which is this question of medication comes up again and again. A lot of very interesting questions about medicine, and I can club them into two groups. One is really about the limitations of medicine, when they don't work, when they have side effects, which clearly, as you know, with some of our patients, it feels like we're adding insult to injury. So you have a patient who says, I'm not ill. We're giving them medicine and their families are saying, much better, doctor, but there's a side effect. And the patient will only focus on the side effect, not on the benefit. Just, I have put on weight, and these are legitimate. I have put on weight, my periods have stopped, my legs are restless. And these are very legitimate questions, and I'm not begrudging the patient the right to ask these questions. But the second is there have been lots of questions with respect to what, this thing that comes up with all our patients, which is the families intervening and saying, but the patient is very lethargic. How do we know your negative symptoms are not being caused by the medicine? I was going to ask you that question. No, I think from a personal selfish point of view, just as a way to explain to families that yes, that the medicine is both designed to help, but can actually add to the negative symptoms by adding a bit to the lethargy, the sedation. How would you address this question? Well, I think, forgive me, Banaja Patnaik has asked this question.
It's a very interesting, very legitimate question.
Yeah, so Banaja Patnaik really has asked this question. So over to you, sir.
So, negative symptoms, as we described, have begun to appear in the process of this disease called schizophrenia. Even before you started them on medication. Watch this carefully. You're beginning to withdraw. You become less interested. You lack motivation. You do not talk much. You do not initiate conversation. You show no interest in externalization. All those things are there before the onset of the disease. We have said also earlier that medication, whatever medication we have, do not improve negative symptoms. Very little improvement, if at all. Do medication cause negative symptoms? By using the technical word negative symptom, I would say I would look at it differently. Can medication cause dullness? Yes. Can medication cause slowness? Yes. Can medication cause dulling of the brain sometimes? Yes. Can medication make you not want to do anything and sleep more? Yes. So how do we address that? So you revisit this set of medication the person is taking, go back to the doctor and say, before we started on this medication, these were not there. They have now seem to be appearing. He is sedated, therefore he is dull. He is not interested, he is not interactive. Is there anything we can do to reduce this, which are side effects? Yes, we can certainly do. There are certain medications which are more sedating than other medications. So the doctors will have to choose which are the medication they are actively antipsychotic. That means they act against psychosis, helps schizophrenia, but does not cause so much of sedation. Can the dosing be reduced? Can the morning dose be combined with the night dose, give in the night as a single dose, which is commonly done? Remember, most psychiatric medication, especially in schizophrenia, all of them can be given as a single dose at night because they have what is called a half-life of more than 24 hours, which means when you give a medication, this acts for 24 hours. For them to attain what is called a steady state level, it may take a week or two. So during that phase, we may want to make sure that the person is on medication through the 24 hours. We may give it 2 times a day. Most patients do not need 3 times medication. The chances are, if you give more times a day medication, the chances of stopping is very high, missing it very high. So maximum 2 times a day. In a matter of 3 to 4 weeks, you should be able to, in most instances, give it as a single nighttime dosage. Therefore, by tweaking the dose, the timing, the dosing, adjusting the medication, change of medication, you will be able to tackle most of these so-called negative symptoms, which are not negative symptoms. They are side effects of the medication. When I'm talking about adherence, I just want to add, total non-adherence is completely not taking medication. There are people who say, oh, weekend, I take off. I don't take medication for the weekends. I take medication as and when I please. Total non-adherence, partial non-adherence, are the ill effects the same? Identical. No difference. Therefore, adherence is an absolute must. But do we all adhere to everything that we aim to? Do we go to gym after planning to go to the gym the beginning of the year? We go for 1 week, second week we say we'll go to after weekend, then we'll say we'll go to alternate days, and by 4th week, your New Year resolution has gone for a toss. So human beings by nature are non-adherent even for the things they wish to have. So schizophrenia is no exception. You give an antibiotic for 5 days, I got better in 2.5 days, doctor, I stopped it. Aha, no aha. You have made the bug resistant to your medication. The next person who's taking the medication because of the same bug is not going to respond. A full dose of 5 days, most people do not take antibiotics. Non-adhering to simple medication is something which is common with many people.
Thank you, sir. I was just going to say we're on around the 100 mark. So, Ms. Padma, if there are others waiting, would you please apologize to them and say that we'll share the recording with them with Dr. KS's consent? Apologies, because it's unprecedented. I'm not surprised that this is such a popular topic. Sir, Dr. Sachdeva asks a very interesting question. It's a question that I've often said no to, but I'm beginning to wonder. One of my patients who is in a very good marriage, is very compliant with medication, adherent to medication, and is somebody who's taking one particular medicine, amisulpride. He has never responded to another drug. But his wife has been saying for some time, you know, doc, we keep increasing the medicine for a while, and then for a while it holds my husband, and then he becomes ill again. It's almost like he is becoming tolerant to it. Now, in medicine, we would say that there is not, you know, that these antipsychotics are not meant to cause tolerance. But Mr. Sachdeva or Ms. Sachdeva have asked the same question. Does any sort of tolerance happen to patients due to long-standing taking, for taking the medication for a long time? And what they've said is, I mean, benefits are not there, but the medication just gives side effects. Is that something that is a recognized effect where patients stop responding to an antipsychotic that they once responded to, but only then just derive the side effects without the benefits? Is that something you have seen, sir?
Of course, yes. I mean, it's not, I would say it is not uncommon. So the first dictum is, have we achieved the full dosing that this medicine is expected to be given? Amisulpride, some people go up to 800 milligram. In my opinion, it's a pretty big dose. Also remember, the more you increase the dose, more side effects that medicine can give you. So his question is very valid. So what do? You have given the maximum dose tolerable by this individual, which is variable from patient to patient. Some patient can tolerate only 200 milligram of amisulpride. Some people can tolerate 400. Some people can tolerate 600 without causing major side effects. So what do? Patient is not getting benefit, but side effects are very prominently present. Simple thing to me. There are other antipsychotics that are available. So I would introduce this individual to another antipsychotic, which is possibly a good antipsychotic with a similar action, sometimes with a better action, with less side effects. So we do what is called crossover design. You introduce a new medication, cut down some of this medication, because any new medication may take about 10 to 15 days to achieve what is called peak plasma levels. By then, we don't want to withdraw all the medication abruptly and wait for a relapse to happen, what we cause. So we introduce a new medication, withdraw one by one, see if the new medication is achieving the purpose for which the treatment is offered. And most often than not, it is possible. My another bee in my bonnet, if medication orally is not giving benefit, combining with the lack of adherence, I would ask the question, does this individual need a long-acting injectable? What are long-acting injectables? Long-acting injectables are those what we call depot preparations. Depot meaning it is inside the system in the individual like a depot. You give an injection. Some of the injections act for 2 weeks, some for 3 weeks, some for 4 weeks. Some of the newer antipsychotics act for 4 weeks with practically no side effects. Let's say there's a particular injection we give once a month. It is 100 milligrams. The technology is so superior and so stupendously achieved. Every day, 3.3 milligram of this medication is released into your system. The remaining 96.7, I think I'm 96.7, I think my calculation is right, is there in the system. The next day, another 3.3. Every day, 3.3. I think it's a fascinating research finding. How do you make a medicine given into you in the form of an injection releases only this much every day? And that gives a huge advantage. What's the advantage? Whether you take medication orally or not, we say people are not taking adherence, this medicine in your system, it makes sure that the body has the medication in your system. Today, this has become one of the methods of managing those who are having repeated relapses. The pity is some of the doctors don't address this issue with the families or the patients. I ask them, would you want to take medication every day or want to take an injection once a month? You'll be surprised. A good number of them say, I don't mind taking an injection once a month. Initially, you may need injection plus tablet. Gradually, you may be able to withdraw tablets. When you give a tablet, what is called the peak and trough happens every 24 hours. That means the peak happens up and 24 hours, it goes into the trough, meaning there is no medication in the system. Therefore, you have to give it every day. Imagine an injection that can be given once a month, where you get the medication every day to the desired effect. And in fact, I will go further to say One of those preparations are available in European and American market, where you give the injection once in 3 months. A further research has happened, which is already released in the European and American market, where you give the injection for schizophrenia once in 6 months. That means 2 injections per year. Can you ever imagine this is possible? When I joined psychiatry in the 70s, we would have poo-pooed this idea. Impossible. But it's available today. So, you as family members have a right to go and talk to your doctor and say, hi, I believe this is available. Can we try this? Those oral medication, if they're not helping you, injectables may help you. The question I ask myself is, if you have a member of the family who has, say, cancer, will you go and give the best treatment that is available in the world? Or you will say, oh, chalta hai, I'm okay with this. I will not give the treatment continuously. You won't do that. A cardiologist makes sure his patient does not come back with a second heart attack. Why can't psychiatrists do that? We should. Long-acting injectable is the answer for such instances.
Thank you, sir. I was going to ask you a problem that I have had a lot with my families, which is it feels like we are not starting at zero when we talk. I was going to say Dr. Lata has made a very useful point about psychoeducation. But I must confess, I tend to be sometimes cynical about the term psychoeducation and its impact at the point that you give the information. I have met patients, and I'm sure we all have, of somebody who says, you said that on day 1, but it has taken me 10 years to accept what you have said. And I wonder, when I see some of my patients, the stigma against mental illness, owning a diagnosis, etc., makes my patients do 2 things and their families. So today I had this amazing woman a young woman who's made an amazing recovery from very complicated schizophrenia. She has had reflex hallucinations. When the fan goes on in the house, she can hear voices. And she also has epilepsy. She has done amazingly well with both. But the moment she has been better, the very predictable thing came up, which is, okay, time now, we're going to think of getting her married. Can we now come off all the medicines? And my heart sank, because this thing of the joy of seeing this young person doing so well was immediately kind of reduced to close to zero by thinking, okay, because there is this belief that medicine is bad. And it is not just from patients. Every one of my psychology interns seem to be inoculated a bit with this idea that medicine bad, therapy good. So we are fighting. It feels to me that I'm not starting at zero. I'm having to explain that medicine will not damage them. Yes, our medicines do have some side effects, but nothing compared to what the effect of schizophrenia is. How do we think, now you've spent 50 years in this field, sir. What is an effective way? All the Instagram stuff that I see is on nonsense. It's a retail end of psychiatry on mild anxiety, mild depression, doing yoga for mild anxiety, which is wonderful, but nothing about schizophrenia. How do we get this out there that actually there are limited ways of treating schizophrenia, and the sooner we treat, the better? How do we work against this? How do we get it so that one day a patient's family will come open to the concept that yes, their child is ill and we can treat them and they'll get better, and the treatments are not perfect, but no medical treatment ever is. How do you suggest we tackle this problem, so both as doctors but also socially?
A tough question, but let me come back with a thumb rule. What we call a thumb rule. 1/3 of patients with schizophrenia will recover well and go back to functioning near normal. 1/3, the second 1/3 will recover well, but not completely, fully well, but they'll be able to function, maybe with certain deficit, but they're still functioning. They can hold on to jobs. And I had a patient who was working in IBM 30 years ago, he came to see me because he said, IBM director and the then president of America, George Bush, were conspiring to get him out of his job. He was a small fry, but the delusion persisted with him. It's even today. But he could not go up the ladder, but he functioned well. But he's on medication. Do you think I should take treatment? every 6 months you will come. Do you think it's time to stop? No, it's not time to stop. It's time to discuss. Negotiate. So continuously take medication. Why is he taking medication? He knows when he takes medication, he's at least holding a job. So you're asking about how do we contend with this? How do we make sure that, what is the question again? You're asking me what is it? I digressed.
So this question of how do we solve the problem of patients' families' stigmas getting in the way of basic psychoeducation, immediate treatment, adequate treatment, because it seems like we have to break down the walls that seem to separate us before we start treating. I don't know many other illnesses in which I have to spend so much time trying to convince both patient and family that, look, there is an illness and yes, we must treat. How do we make it easier for the patients and families how do we do this?
Because it is in the realm of which is not visible to their naked eye. Because they cannot do a test and find an answer in a blood test or even a brain scan. They're not going to tell you a diagnosis and say, these are the problem is. They find it very difficult to accept this concept. Yeah, how are you making a diagnosis? We are making a diagnosis based on your conversation with you and listening to the family members. We listen to them, we ask them questions, we ask the families, the patients, and see a group of symptoms, and we make a possible diagnosis and treat. Despite all that, there is always a hope against hope in them that this is not true, this is not possible, and this will go away. No, it's not going to go. How do we make them come early? Because there must be a concentrated effort to educate the public about early signs of schizophrenia. How early is early? Maybe the World Schizophrenia Day next year could be in WHO, how to recognize early signs of schizophrenia in the population.
Yes.
Is important because this is the kind of a problem not just we face here, it is across the globe. I get better, I stop medication. Shall we stop now? Shall we stop now? Even before we write a prescription, they ask you, how long do you think I should take the medication? You're not even taking the first tablet. So the desire to stop something is so great that you don't think it is a continuous treatment to be taken for a long time because it is something that is unacceptable to them. I asked them, does anybody in the family have diabetes, thyroid, kidney disease, blood pressure? How long do they take treatment? Oh, that is a very different kind of illness. No. If that is an illness which is below your neck, this is above your neck. It is in your brain. Do you cure schizophrenia, doctor? I asked him, do you cure hypertension? Do you cure diabetes? Do you cure thyroid disease? By which definition is you stop the medication and you have no symptoms. We maintain the illness. We maintain the condition so that you do not suffer. We maintain your blood pressure. Because your sugars are within normal limits in the last 6 months, do you discontinue treatment? You don't. The story is the same with the disease called schizophrenia. But the consequences of stopping is damaging. So second 1/3. The third 1/3, despite all our efforts, they may function far below par. This was told to me 30 years ago, 40 years ago. I don't think with advancements we have made it different, but we have made them far more functional, less suffering from side effects with the newer medication in the group of people who are well. So this is the nature of the disease. But can we do something to prevent them reaching the last 3? Yes. By making certain you treat early. We use a term called DUP, duration of untreated psychosis. The longer the duration, greater is the time to respond. Is this dictum same for all? No. Sometimes you are surprised by the fact people with acute psychotic episodes, schizophrenia, we think, I bet this person will recover very well. We are completely foxed because the person keeps repeated relapses despite treatment. Therefore, it is important to recognize the continuity of treatment is paramount in this disease, like in any other chronic medical condition. What do we treat in medicine? Cure infections. So I think the continuity of treatment is absolutely essential, like you treat any other medical condition. And one point I want to tell people. Let us say a physician or surgeon, for example, sees 10 patients with appendicitis in a matter of, say, 3-4 months. The surgeon knows, maybe the patients know, that the appendix is in the right lower part of the right side of the abdomen. Surgeon will go there, do a scan, operate, take it out, send you home. All appendix are there on the same place for all 10 people. 10 people with schizophrenia, are they same? No. Diagnosis is same, symptoms are different. Response is different. The family structure is different. Family history is different. Family support is different. So each person with the same diagnosis is different from the next person. So each one is challenging. It's not the same. We don't treat the diagnosis. We treat people.
Thank you, sir. So we're getting up to the 90-minute mark. Are you okay if we go over a few minutes, because still lots of questions?
I'm game.
Okay, sir. Thank you. So this is a question that comes up a lot, particularly with your patients. This issue of duration of untreated psychosis seems to be partly related to the fear of families of compulsory treatment. The fear of compulsory treatment seems to cause a lot of problems for my patients, because families will say, is it better, compulsory treatment might result in trauma. They'll be angry against their will. They will never forgive us. And yet they suffer and suffer in silence. Sometimes they will come and say, please help us. We have been discussing this endlessly. The Mental Health Care Act permits all sorts of compulsive are kept from their treatment, not by their illness, but by the fact that they're frightened of the effect of compulsory treatment. So if we were to put this question, this treatment worth any trauma that occurs, what's your view on this one, sir?
I think it's something that I've encountered a lot in my early years of practice, both in demands and later in private practice. These are very genuine fear from the families. I bring her, drag her, and take treatment, and I will never be forgiven, and there will always be a blot in our relationship. The fractured relationship will never heal. To my surprise, I have not encountered this kind of a phenomena in many. On the contrary, what I found is, when you recover from a severe illness like schizophrenia, you turn around and tell them, hey, mom, dad, thank you very much. Doc, I didn't realize it. I didn't realize I was ill. I'm able to go back to drawing, painting, singing, dancing. I couldn't do before. You have given my life back. I know I was difficult at that time. I know I resisted. I hated them for doing that. But I'm grateful to all of you today, because I'm a human being all over again. This I've heard more than I will hold you responsible for all your life. There are people who have threatened me, I'm sure Aditya too, that I will take you to court and see that you are debarred, your license is removed, because I am trying to take them to take treatment and they're unwilling to take treatment. Touch wood, in all my years, nobody has taken me to court for this reason. And if anything, they are thankful to you because you helped me at a time when I was not able to help myself. And you must see the joy and the tears of, satisfaction in the family's face. That oftentimes they have come and told us, we are back as a family again. Now, I think this is common. Sometimes this fear is exaggerated, but at any given time, this is very real. We as doctors have to stand by them and say, our experience tells us this is not going to be a lasting damage. On the contrary, it's a reverse. We are correcting the damage to the brain. Therefore, the person's resilience, person's rationale, person's self-worth, and the dignity coming back, they will thank you for it.
Thank you, sir. So this is another question that, in June, I'm going to Germany. The Max Planck Institute's having a conference on the WHO report, which said that outcomes in schizophrenia are better in countries like India. So that I think the whole conference is designed to ask two questions. Is that really true? Number two, if so, why? So my thesis, the thing I'm going to do in the talk was to say that I think outcomes are better in those who are treated, but largely the magic ingredient is the involvement of the family. That it is not necessarily that as doctors we are better, that the same medicines that we have, all of that. But family involvement is huge in India when you treat someone with schizophrenia, and the family seems to are the magic ingredient in the outcome. So my question to you is that correct? Do you believe that outcomes in India are indeed better? Because that was what the original researchers said, but people like Vikram Patel have questioned it. Secondly, what do you think, if the outcome is better, why is it better? What's your view on this based on your experience, sir?
Unlike most other medical surgical conditions where an individual is affected, in psychiatric illnesses, especially schizophrenia, the entire family gets affected. There is what is called an index patient, and there are secondary players around that patient. They all get damaged. They are perplexed. They don't know what to do. They're helpless. Whatever step they take seems to be wrong from the person's individual illness point of view. So, but do they give up? The beauty of this country and the beauty of these families here are they do not give up. Rarely I have seen family come and say, my son, daughter, or wife is unwell. I want to wash my hands off. I can't handle it. I am amazed at the resilience and the tenacity and the compassion they all have for an ill individual. That is something outstanding. Therefore, this component cannot be replaced by any medication or injection anywhere in the world. IPSS study, you might remember, Aditya, was done about 35, 40 years ago in several centers, in 9 centers in the world, including in India. The Indian study showed the outcome was the best in India. They replicated it a few years ago. Same story. Wherever there is a family support, and families are supportive, God help you. My sister, when I said she was ill towards the end, she was so bad. She became ill age of 17, 18. She was ill for about nearly 20 years. Very severe schizophrenia. She would keep the notebook or stitching upside down, take a needle and try to, make movements. I feel is making a stitching in a book of stitching, in a book where my mother used to sew. And she was doubly incontinent. She would pass motion and urine in the bed. The mother-in-law looked after her. Husband cared for her. He would take her every day, every time she soiled her dress, take her to the bathroom, give her a bath, wash, change the dress, and without losing his cool even once. We have often offered to him those days, why don't you marry someone else if you want? It's understandable. She had a child. The child is now 44 years old. He said, I chose to marry her. I will live with her. Now, this is what you will find here. Several hundred families, thousands of them. So this component of the management of the problem in schizophrenia in this country is very unique. Therefore, those outcomes are likely to be better than you seek a distance. I'll give you a small little example, the digression. I have a family whom I've been looking after this lady for schizophrenia for over 40 years. Our elder sister is in the US. She's a psychiatrist. And her elder sister's only daughter developed schizophrenia a few years ago. And she, being a psychiatrist, she could not treat her own daughter. She had to go through the mill of going to a GP and then refer to a psychiatrist. She refused to go. So she's wandering around. The recent thing I heard was 3 months ago, she wandered out of a Orlando holiday where she had gone with her cousins. When she wandered out, she goes to the police station, gives an undertaking that her family shall not try to locate her. And that is US of A, the so-called advanced country. Advanced in what? I can give you several examples. So the mother, who herself is a psychiatrist, is so distraught. I told her, in India, we would have brought her into admission in 24 hours, willy-nilly, hook or crook. Now, this is individual freedom. Where a patient with schizophrenia, unless he or she chooses to see a doctor, which they will not, even if they go, a family member is not allowed inside the doctor's chamber to give 5 minutes of history. How do you think they will recover? Are you surprised their outcome is poor? I would say outcome is rotten. We are better off. We care for the welfare of our patients, not just the patients and their families and the community. We will stretch ourselves to do what is right and not what is legal. I'm sorry. I mean, so to speak. So outcome, I think, is better.
Thank you, sir. That was very helpful. I think Ms. Harvandan Kaur Bedi has said something that's important, because I think we talked about marriage, and I know I said my heart sinks, but she said, sir, but marriage is a big issue. If the doctor doesn't taper, the patient will abruptly stop, and the other party may not be informed. In fact, that was the discussion I had today with 2 of my patients, which was, please, please, please tell the other party that that this is what's happening, especially because from a very selfish perspective, if you're expecting them to look after your loved one, the first time there is a relapse, do you think they're going to go to a doctor, or they're going to bring the child back to you, no matter how old it is? So I thought it was important. I think Ms. Bedi's point is well made, that I think the social circumstance in which we work, marriage is a very important goal for many people. And many families feel that it is the ultimate marker of wellness. And I think we have to work with our families and say that although marriage is not an important thing to us, we accept it is to them. And I don't know, maybe in the future, we will be able to have people proudly say, I have schizophrenia and I want to get married. That would be the way to do it. And I think for me, I feel I've got to that stage that you have already been in for many years, which is I don't want us to hide this illness anymore. It is what it is. It is not my patient's fault. So we should not hide it, nor should we work with our patients to hide it. Let us be out and proud with schizophrenia. So we'll see. But
no, let me just handle one question, which is part of the same thing.
yes, sir.
Marriage is a big issue. Harvandan Kaur Bedi.
That's the one, sir.
Big issue. It will not be informed that the doctor does not taper. They will abruptly stop. I think
that's the
very careful
point,
about when and how do we taper. Do we taper because of marriage? No, I don't think that's a correct approach. We taper because we think the patient is ready to take a lesser dose of medication, and that also under caution. Every time we reduce the dose for a particular event, and we are going to land in trouble. So it's not a question of tapering. They may stop abruptly. What happens? As I said, within 10 days, relapse happens. 15 days, 2 months, 2 weeks, it can happen. And within a 1 month, if the relapse happens, the whole entire marriage collapses because you have hidden that information. No, but if you inform them they have schizophrenia, they will not get married. Well, that's another story. But should we be honest and upfront? I think yes. Sometimes I have known patients who do get married. They inform them, explain to them. They come to the doctor like us to have a discussion, open discussion with them. I make it a point to discuss with the prospective bride and the groom. Sometimes keep the parents outside of this discussion, because if the husband and wife decide, the to-be husband and wife decide, they want to keep it to themselves, not bring the family in, so be it. So, horses for courses. Each one is individual, therefore, it is not a uniform policy that can be applied to every situation related to this kind of a marriage situation. And remember, everything is not hunky-dory in every marriage situation like this. So we have to wait and see how this evolves. What is the percentage of mental illness? Muralidhar sir, 1% of the population is supposed to suffer from schizophrenia. Schizophrenia alone. 1% of the population across the country, across the globe. Aditya, yes.
So there are lots of questions about yoga and pranayams, which is, should it be practiced? Can it be practiced? And I think Banuja Patnaik has said, when my daughter is doing any pranayam with medicine, she felt more side effects and more disturbed. Mr. Sachdeva says, I understand some forms of Brahmari pranayama should not be performed. So, you know, this is something that we often get asked. What do you tell your family, sir?
Yogas come out to be seen as the panacea for everything, including mental illness, including schizophrenia. The only thing, and let me underline again, the only thing that is permissible in schizophrenia of any form of yoga is yoga asanas. And what kind of asanas? What we call dynamic asanas. What is a dynamic asana? Surya Namaskar. What is a static asana? You sit in Padmasana and close your eyes and meditate. Is meditation advisable? Definitely not. Brahmani to be done? No. Some people benefit with pranayama, but some people, as we say, develop side effects. So, by and large, we try and avoid giving any advice on yoga, except to say asanas can be done, but not static asanas where you sit in one posture, but dynamic asanas. The very fact that you try to do any kind of a meditation and all kinds of thoughts, all kinds of disturbed thinking can happen in your brain, which can cause a relapse. I've had several patients coming from yoga schools when they do not follow this simple advice, only to have a relapse. On top of it, some of the yoga schools go one step and go ahead and say, if any of you are taking medication, it is now time to stop the medication. It's something which most people want to hear. Lo and behold, relapse. So be clear that asanas can be done, dynamic asanas can be done, because the minute you open the other possibilities, you do not know who can be given what, and this becomes a prescription to be shared by all, for all and everybody on. So I think we should stick to asanas and Surya Namaskars.
So last question, sir, because I know there are still many more questions coming up, and I'm going to ask a favor on behalf of all the audience. Would you agree to do another talk on the treatments for schizophrenia and maybe the pros, the cons, and the side effects, so that we just focus on the treatments? And I think we know one Dr. Lata is part of the audience, and as the psychologist that we trust above all with respect to schizophrenia, maybe we can ask Dr. Lata if she will do a session on the psychological therapy for schizophrenia, the pros, the cons, and the evidence. But coming back to the last question, sir, which has come many times, so I can't ignore it, which is the role of ECT in schizophrenia has been asked several times today. And I kind of thought, okay, we'll wait because it's not central to the issue, but it has been asked. What do you tell your families on when and why do we use ECT in schizophrenia?
Okay. Should ECT be used in schizophrenia? In selected cases, definitely yes. It is very beneficial. It cuts down the acute psychotic symptom, which can be very destructive very quickly, rapidly, and gets the patient to a functional level where medication begin to act and they respond to medication. There are conditions like catatonic schizophrenia, where a patient becomes mute almost in a what looks like a comatose state, they are not comatose, like the brain is comatose. Their body seems to cease to function. They are in a kind of a freeze mode. They cannot talk, they cannot swallow, they cannot pass urine. I've had patients holding urine for 48 hours, 2.5 liters have been drained. They do not swallow like this for hours together. And you raise your hand, they may be in the same position. As long as you leave them to be there without showing any discomfort or pain, this kind of a catatonic state responds like magic for schizophrenia, for with ECTs. ECTs, there's a lot of abuse about ECT, not about the usage, but about the talk about abuse of ECT as a measure of treatment. If appropriately used, I think ECT is a very useful method of treatment. I don't admit, most of people who know me, they know. They all go to Dr. Aditya's place for admission and we discuss. And several times when we agree the ECT is beneficial for the patient, it has never failed to deliver. Therefore, ECT is a useful treatment when used correctly, appropriately, and it's very beneficial. And if there is a patient with schizophrenia who has got a very strong suicidal idea, which may be secondary to hearing of voices which command them to jump in front of a bus, to run and dash against a vehicle, to jump out of the window. If these voices command them, we call them commanding hallucinations. Unfortunately, this commanding hallucination, patients have no power to resist them. They act on it. And such patients are very strongly, can be suicidal. And they benefit a lot. It is said, literature has told us, we know it, more people with schizophrenia commit suicide compared to people with depression. Therefore, ECT used appropriately is an extremely useful and life-saving method of management. Dr. Aditya uses in his nursing home quite a bit of ECT with enormous degree of good outcomes. So I think 2 weeks ago, I sent a patient of mine who I have treated the grandmother, the mother, and the granddaughter. She discontinued medication. Why? Because she was doing very well. She joined an IT company, earned well, and she stopped medication because her boyfriend said, "Why are you taking medication?" Lo and behold, stop medication. She came back in a mute state. She was like that. She would not talk. She would not respond for 48 hours. He was in the same place. Sent to Dr. Aditya, gave her a course of ECT, shared the picture of the mother and daughter smiling. Such a sense of satisfaction. If she goes back to medication, she'll function well, she'll get a job again. Therefore, let us not go by the media massacre of ECT. Let us not go by the way movies depict ECT. I don't need to describe what they do in the movies. That's not the way it is done. It is done in the most humane form. It does not cause brain damage. It actually saves the brain. Thank you.
Thank you, sir. I think we're unsurprisingly, we've now 106 minutes and going, and there's still a full audience, and there's still, I think a lot of people have echoed this thing of please one more session, sir. So I think we may trouble you at some point, not in the distant future, but maybe we should do a series on schizophrenia so that we cover all the relevant aspects that are particularly relevant to the families and the clients and our students. I wanted to thank you very much because that has been an extraordinary session, because it was really, I think you answered a lot of our questions, and it comes, as I said, from a place not just of academics, but 50 years of clinical experience and personal experience. I think on behalf of our audience, I wanted to say thank you very much. Lots of very positive regard, including somebody from Malawi. I think we had somebody just now saying we've just attended. So from very far afield, it's not just India, we've had several people. Maybe next time we'll have to increase the limit from 100 to more so that more people can come. with your permission, we'll upload this to a YouTube site, and I think we're going to have a new YouTube site, so we'll put that up there. So I wanted to say thank you on behalf of everyone. Any last words, sir, before we go?
Thank you, Aditya. As I often tell people, I'm addicted to talking, addicted to teaching, and I love it. And thank you very much for giving this opportunity and the kind of incisive questions, which is just asked not of your interest, of what the kind of question that come to us as clinicians from various families. We may not have answers to all the questions, but we can show you right there, possibilities there. I think we can do several things on schizophrenia. What are the various kinds of medication and why are they used? And what are the side effects one can expect? What do you do when you get a side effect? What are the psychological supportive treatment that can be offered for schizophrenia? Dr. Lata and her ilk will be able to give such kind of an answers. I think very importantly, where and how and why rehabilitation? What can one expect for rehabilitation? I think we can do series of these talks, maybe once in 4 to 6 weeks. I think I'll be delighted to be part of this if you ask me to do it again. Thank you, and thank you for being there, and thank you for all the audience for such a lot of interest. It just shows people are thirsting for information, knowledge, and the correct way of conveying things to them. It may not satisfy everybody's family member who has an illness, but we try to be helpful to everybody that is available, and we will do it again. Thank you very much for asking me to be part of this.
Thank you, sir. Once again, thank you. And thank you, Ms. Padma, for co-hosting this. Thank you to the audience for coming. Apologies those who could not get in. Next time, we'll also stream it on YouTube. I think it'll make it much easier for those who can't participate on Zoom to actually participate in the talk nonetheless. Thank you all, sir. And
Thanks.
have a good afternoon.
Thank you. Bye-bye.